Hello everyone, this is Designed for Medics, and today we will be talking about the pathophysiology of angina and myocardial infarction. In order to dive into this topic, we first have to review the pathophysiology of atherosclerosis. In case you forgot, atherosclerosis is patchy thickening of medium and large arteries, which reduce blood flow. The generic term for this is arteriosclerosis, which is described as several disease processes where the arterial wall becomes thickened and loses elasticity. The process of atherosclerosis starts at a relatively young age and is accelerated by smoking, diabetes, high cholesterol, and genetics. These are our risk factors. This leads to an increase in adhesion molecules. Adhesion molecules allow for the recruitment of monocytes, and these monocytes send intracellular signals that trigger smooth muscle cell recruitment into the tunica intima. This causes an increase in the amount of inflammatory mediators that are present, which leads to an increase of vascular permeability. At this point, monocytes and LDL both enter the tunica intima. LDL is known as low-density lipoprotein. Monocytes engulf LDL and turn into fat-laden foam cells, which are immobile. This marks the start of plaque formation. The plaque begins to build towards the tunica externa, resulting in a decrease of blood supply. This plaque now begins to solidify. Plaque builds towards the lumen, which results in a turbulent blood flow and decrease in perfusion distally. There is also a notable oxygen supply to the endothelial cells that is decreased at this time. At this point, the fibrous cap forms and it is prone to rupture, especially with the turbulent blood flow. Just a quick recap on the pathophysiology of atherosclerosis. You can pause your screen at this time if you wish. Now we can start talking about angina. There are two types of angina, stable and unstable. Stable angina occurs when atherosclerosis develops and plaque builds towards the lumen. This leads to a reduction of blood supply to myocardial tissue. However, there is enough to meet demands while at rest. When the patient begins to exert themselves, the oxygen demand, or MVO2, begins to rise. Due to the atherosclerosis, there is an inability to meet oxygen demands due to the plaque occluding the blood vessel. This leads to a decrease in oxygen distal to the plaque and results in symptoms of ischemia at myocardial tissue, otherwise known as cardiac ischemia. When the patient takes nitroglycerin or rests, the oxygen supply will return to adequate levels and the symptoms disappear. Some symptoms noticeable during angina are diaphoresis, generalized chest pain, usually a crushing or a heavy pressure sensation. It may radiate to the jaw, and nausea or vomiting. Here's a quick flowchart showing how cardiac ischemia develops from stable angina due to the increase of exertion and the inability to meet oxygen demands. Some notable symptoms are increased respiratory rate, diaphoresis, nausea and vomiting, and visceral pain. Now we can discuss unstable angina. This typically develops due to the increase of plaque growth or the rupture of a fibrous cap without completely occluding the blood vessel. The most important thing to remember is that nitroglycerin will not work on a patient with unstable angina. It can occur randomly. It is a warning sign that the person may progress into a myocardial infarction. As the blood clot grows, blood flow is reduced, and 50% of people will have a myocardial infarction in the future at some point. If this disease is not treated, a myocardial infarction can occur. This is commonly known as a heart attack. To start things off, the fibrous cap ruptures. This allows plaque to spill into the blood vessels and release thromboxane A2, which attracts platelets. Platelets will then aggregate and form a clot, occluding the blood vessel. The severity of the myocardial infarction is dependent on where the fibrous cap ruptures. More platelets are recruited and a fibrin mesh forms. This inhibits blood flow distal to the clot and results in ischemic chest pain and necrosis of myocardial tissue. The myocardial cells quickly switch to an anaerobic metabolism, which increases the production of lactic acid, further exacerbating the symptoms.